Alright guys, welcome to my YouTube channel. I am your ophthalmology educator, Dr. Manish Chhabra, and in this video I am quickly going to discuss the foreign medical graduate exam previous year questions. So in this video I am going to take 10 questions and in a very crisp and concise manner so that it helps you during your revision at nth hour, right? And in case of any queries, you can get back to me on Instagram, Telegram, and I'll share my WhatsApp number with all of you in the end, right? चलो तो शुरू करते हैं. First question is, patient has distress on reading. On examination, there is no problem of short-sightedness or long-sightedness, but Sharma test reading is 5 millimeter. What is the treatment in this case? So what is this Sharma test? Sharma test is, there is a Sharma strip which is Whatman number 41 blotting paper. You put it on the junction of medial 2/3 and lateral 1/3 and ask the patient to close the eyes for 5 minutes. Then you take the reading, yes, and if the reading comes out to be more than 15 millimeters, so there is a wetting of the Whatman number 41 blotting paper. So that means the tear film status is normal. If it is 10 to 15, that actually tells you that it is borderline. If it is 5 to 10, that is moderate dry eyes. Now if it is less than 5, it goes in category of severe dry eyes. So here it is saying that it is 5 millimeter, so that goes in favor of the severe dry eye category. If there is having dry eye, so what will be your treatment? So it will be lubricants. You will actually supplement the tear film with the help of lubricant, which is artificial tear drops. और कौन सा lubricant हम use करते हैं? Commonly used is CMC. CMC is, yes, so it is a methyl cellulose preparation. And there is hydroxymethyl cellulose, there is carboxymethyl cellulose, there can be other lubricants which are available, but yes, hydroxymethyl and CMC, they are the most commonly used lubricants. Okay, all right. Now the second question, a patient presents with hard painless nodule growing externally away from the lid margin. I always say in my lectures, if it is growing at the lid margin, on the base of the eyelash, you call it as stye or hordeolum externum. Yes, and stye is what? It is inflammation of hair follicle. Yes, I'll be writing less, but I'll be speaking more because this is your revision. This is not the primary class. Yes, hair follicle, if hair follicle is not in the option, it is inflammation of gland of Zeiss, and it is very painful. There is a very tender nodule at the lid margin, so the treatment will be oral antibiotics, oral anti-inflammatory, topical eye ointment, and there will be expression of the pus during during the course of the disease, and the pain will be relieved. Or you can even go for epilation. Epilation is you are going to pluck the cilia, the eyelash base of which is having hordeolum externum. You also go on for hot fomentation. So that is the treatment of stye, which is at the lid margin. But here they are saying that this is present away from the lid margin. So what the examiner wants you to answer? It is a case of chalazion, boys and girls. Chalazion is chronic infection of meibomian gland. Yes, and it is painless nodule which is chronic, while hordeolum externum is acute. And what is the treatment here? You can go on for intralesional steroid, triamcinolone, or you can go on for IND, incision and drainage, right? If you are doing IND from the inside, you invert the eyelid and you give vertical incision. If you are doing from the outside, you don't need to invert it. You will give horizontal incision and you will express the lipogranulomatous contents of the chalazion. So this is your chalazion. Yes, all right. External hordeolum, I have already told you, and internal hordeolum is actually acute infection of meibomian gland. Entropion, what is entropion? It is inward rolling of the eyelids, not eyelash. If there is misdirected eyelashes, you will call it as trichiasis. Here we are talking of entropion. Okay, and what is distichiasis? Distichiasis is extra row of eyelashes. So trichiasis, distichiasis, entropion, ectropion, and ptosis. Ptosis is drooping of eyelid. So these are all your PYQs. Okay, now a patient presents with bilateral ptosis which is variable during the day and reduces on putting the ice packs. Arey baapre. What is the most likely diagnosis? So you are thinking of a ptosis which gets improved. So what is the purpose of ice pack? Ice pack se kya hoga? Ice pack is going to neutralize or inhibit one important enzyme which is ACHE, acetylcholine esterase. Now if the patient is having myasthenia gravis, what happens in myasthenia gravis? There is auto immunity, there is antibody formation against the receptors, post-synaptic receptors. Yes, when there is release of acetylcholine, since there is damage to post-synaptic receptors, so acetylcholine is not able to act, right? So as a result, during the course of the day, during the activity, so the effect of acetylcholine wanes off, and as a result, the muscle is not able to function well. Yes, but when you apply ice pack, so acetylcholine esterase is inhibited. What is the function of acetylcholine esterase? It breaks down acetylcholine which is present in synaptic junction. Yes, but it is inhibited. So acetylcholine will remain in the synaptic junction for the long duration of time. So it will be able to act quite easily, which will actually not allow the muscle to not act. So that means the muscle will be acting. That is why it is mentioned that it is going to reduce the ptosis. Yes, so we are talking of myasthenia gravis, and ice packs will inhibit acetylcholine esterase. Also injection of neostigmine, the same action. So if there is improvement of ptosis on injection of neostigmine, you will also think of the same which is myasthenia gravis. Yes, that is also your previous year question. Okay, vision acuity of patient improves on looking through the pinhole. This indicates, now please understand, now this is cornea, this is your lens, and this is your retina. So the light rays are coming from infinity, they are being focused here. Now let's suppose that the patient has myopia. In myopia, the size of the eyeball increases, the axial length increases, but the point of focus will remain here only, the previous retina position. This is your R, this is your R1, the new retina position. So here the patient has become myopic because the image is being projected in front of the retina. Yes, but if you will place a pinhole, you can see from this diagram that the peripheral rays, they are getting bent. Yes, and when the patient is having myopia, so the patient will not be able to see distant objects clearly because of blurring of the vision. Why? Because the point of focus will not be one point. So this light will be focused here, so this light will be focused here, this light will be focused here, this will be focused here, and this will be focused here. So you can see that this entire area on the retina is stimulated, which causes blurring of vision. But if you place pinhole, pinhole is a small occluder with a small hole of approximately 1 millimeter or 1.2 millimeter diameter, it is going to obstruct the peripheral light rays, which allow only the central light ray to pass through. Now can you see this, that even if there is backward movement of retina due to increase in the axial length, all the rays are getting focused on other points on the retina, but the central light ray, it is going straight, and it is not taking part in the refraction. But since the pinhole has occluded the peripheral light rays, only the central light ray will pass. And now after placing the pinhole, there will be only one focal point, and all these light rays who were initially interfering with that of the point of focus will now be occluded. So now only the central part of the retina, which is fovea, will be stimulated, and as a result the patient will have improvement in the vision. Yes, so that actually tells me that the patient is having what? Patient is having refractory error. Yes, the patient is having refractory error. Even if there is hypermetropia, let's suppose this is R2 hypermetropia, so the image is focused behind the retina. Again, there is disturbance like this ray, this ray, this ray, this ray, this ray. On placing the pinhole, only the central light ray is going to focus on the center of the retina. It is again going to cut off the peripheral light rays. Yes, okay. Now the fifth question, a farmer presented with pain, photophobia, watering from the eye for last 36 hours on examination, and ulcer is seen, and identify the lesion mark. अब देखेंगे. Can you appreciate the blood margins? Yes, non-defined margins are there. Can you see that this is the main ulcer while this is the secondary ulcer? So this is known as satellite lesion. Yes, satellite lesion. So and you can see that the margins are non-defined. It goes in favor of what? It goes in favor of fungal corneal ulcer. What are the other features of fungal corneal ulcer? So first is signs are more than symptoms, dry looking ulcer, non-defined margins, satellite lesions. The hypopyon will be fixed and it will be sterile or non-sterile. Non-sterile because fungus is the only organism in the universe which has the ability to penetrate intact cornea. Mind you, I'm not saying intact corneal epithelium, just epithelium. I'm saying intact cornea. Now can you name the bacteria which have the tendency to penetrate intact corneal epithelium? Corynebacterium, Haemophilus, Shigella, Listeria, Neisseria meningitis, and Neisseria gonorrhoeae. But this fungus has the ability to penetrate intact cornea. Yes, and so the answer will be satellite lesions. So this was also your FMG PYQ. Hypopyon, I've told you, dendritic ulcer you are going to see in herpes simplex virus keratitis. But if I talk about herpes zoster ophthalmicus, it will be pseudodendritic ulcer, ring infiltrate, ring ulcer, or you can say it is seen in typically acanthamoeba keratitis. Yes, acanthamoeba keratitis, there is ring ulcer and there is symptoms more than signs. There is pseudodendrites, there is inflammation around the nerve, so it is very painful, right? Okay, chalo, now identify the given condition with inward rolling of lid. Inwards, वो अभी तो हमने करा. So if there is inward rolling of eyelid, you call it as entropion. If there is outward rolling, you call it as ectropion. Distichiasis, extra line of eyelashes. Yeah, extra line or row is a better term. Trichiasis is misdirected eyelashes. Where have you read trichiasis? Can you tell me? Can you tell me trichiasis? Trachoma. In trachoma, trichiasis is pretty common. Okay. Even in trachoma, the other important thing is entropion because of scarring. Okay. Now, a child presents with defect in vision, but on examination, fundus is normal. What could be the diagnosis? So they have given very incomplete history, but in such questions, you have to see the options, then you need to mark the answer because defect in vision, fundus is normal. So this is a very vague presentation, hai na? Okay. So what can be your answer here? Okay. Fundus is normal. So defect in vision, astigmatism, refractory error, myopia, hypermetropia, refractory error. So the best answer of this question should be amblyopia. So in amblyopia, there is diminution of vision. Visual acuity is decreased. Yes, but the fundus is normal. Fundus is absolutely normal. So what is amblyopia? It is stimulus deprived loss of vision. What is the most common cause of amblyopia? This is also your previous year FMGE question. The most common cause is anisometropic amblyopia. Anisometropic amblyopia. Now you can say that, sir, cannot it be astigmatism, myopia, hypermetropia? All these three are your refractive errors. If you think that there can be myopia, there is equal chance of hypermetropia and there is equal chance of astigmatism based on the scenario given. But since they have typically told defect in the vision, but on examination fundus is normal, if the examiner is thinking of refractory error, the examiner would have pointed out that there is improvement on placement of the pinhole, and the examiner would not have given the refractive error of all three types in one question. Yes, so either it would have been only myopia, it would have been only hypermetropia, or it would have been only astigmatism, like that, hai na? So the best answer here is amblyopia, and the most common cause of amblyopia is anisometropic amblyopia. So anisometropia is when there is difference in the refractory error of two eyes. Yes, but the significant, you call it as significant anisometropia if the difference in refractive error to eyes is more than equal to 2.5 diopter. What are the other causes of amblyopia? Congenital cataract, strabismus means squint, mechanical cause which is ptosis, then high refractory error. One is anisometropia, another is one eye is normal but the other eye is having high refractory error. Yes, that can also lead to amblyopia. Okay, now coming on to the next question. A child aged 1.5 years is brought by parents with leukocoria and is shown, you can see the leukocoria which is white pupillary reflex, flexor Wintersteiner rosettes. Most probable diagnosis, this is the histopathological diagnostic appearance of one disease which is retinoblastoma. Retinoblastoma is most common malignant intraocular tumor in children and typical presentation is 18 months. So ye dekhiye, they have given a typical presentation. Yes, now can you tell me most common malignant intraocular tumor in adults? It is choroid melanoma. Now can you tell me most common malignant intraorbital tumor in children? It is rhabdomyosarcoma. Most common intraorbital. So there is difference between intraorbital and intraocular. Intraocular is inside the eyeball, intraorbital is between the eyeball and the orbit, that means inside the orbit. Most common intraorbital malignant tumor in children. Okay, buy one get three free. I am going to give you 3 more MCQs. Most common intraorbital tumor benign in children, what will it be? Dermoid cyst. Okay, one more down. Second, most common intraorbital malignant tumor in adults, it is non-Hodgkin's lymphoma. 2 more down. Okay, now last, most common benign intraorbital tumor in adults, capillary or cavernous hemangioma. I hope it is clear. Okay, so you need to know the history. It is not once, not twice, but it has been repeated many times in your previous FMGE examination. Either they will give you flexor Wintersteiner rosette, or they may give you that there is calcification on CT scan, because this tumor consists of calcification. That is why NCCT is investigation of choice. Yes, but if you want to detect the extent of metastasis, because it happens to be via optic nerve, you will go on for MRI. This is also your PYQ. Or they may say that the patient has come up with leukocoria and strabismus and there is hyphema or there is hypopyon. Now hypopyon in retinoblastoma is not true hypopyon, it is pseudo hypopyon, because it is not the lymphocytes which are there in the anterior chamber. Lymphocytes, if there, you call it as hypopyon, as you did in anterior uveitis, but here there are tumor cells in the anterior chamber, so this is pseudo hypopyon. Yes, so all these are features. They will just mix up one or two of these features and they will give you in the form of a history or question. Okay, and the most common age of presentation, you should not forget, it is 18 months and typical history is given here. Okay, after an accident with metal works, a mechanic got injured with metallic foreign body. Investigation of choice. Now if there is metallic foreign body and you ask the patient to undergo MRI, due to very high magnetic field, 1.5 Tesla, 2 Tesla, 2.5 Tesla, 3 Tesla, the metallic body will rotate inside the eye and will damage the intraocular structures, so it is contraindicated. So you always and always go for CT scan. This is the investigation of choice. But if they ask you the first investigation that you will do, first investigation you will do, that is B scan. What is B scan? It is the ultrasonography of eye. So there is a special probe and you do ultrasonography of eye. That is the first investigation. But the best investigation or investigation of choice is NCCT. You will avoid MRI in metallic foreign body intraocularly. Okay, now the last question. A patient comes with paralysis of all extraocular muscles, most probable site of lesion. Now this question is pretty confusing. Now check this out. So there are 3 parts. One is your midbrain, then is your pons, and then is your medulla, right? Now from midbrain there is third and fourth cranial nerve, pons fifth and sixth cranial nerve, rest remaining cranial nerves are via medulla. Now they have asked all extraocular muscles are paralyzed. Now third and fourth, so you know third extraocular muscle, third this cranial nerve, मेरा ध्यान फोन की तरफ चला गया था, one message just came. Okay, so third cranial nerve supplies which extraocular muscles? You know na, SO4, LR6, rest 3 है ना, and that means remaining extraocular muscles are inferior oblique, inferior rectus, superior oblique and superior rectus. So these are the 4 muscles, and fourth cranial nerve supplies superior oblique. So 5 out of 6 extraocular muscles, they are supplied by the nerves which are originating from the midbrain. Yes, but here they have given all extraocular muscles. So of course the 6th cranial nerve, which is abducent nerve, it supplies lateral rectus. So the best option to mark here is your midbrain. So hence it is the answer here. All right, so that was it from my side. I'll be coming up with more FMGE PYQ discussions. In case you have got any doubts in any topic, not only these 10 MCQs, but any topic in ophthalmology, you can get back to me. You can WhatsApp me and I will be happy to respond to you. WhatsApp. All right, 9814111330. So yes, keep studying, keep reading. हमारा exam 12th January को है, and I assure you that we are going to rock the exam. Yes, best wishes.